seats down here and over on this side as well. So you don't want to stand the whole time. If you're going to fall asleep, it's easier to do that if you're in a seat. It is really a great pleasure to be here. I really mean that. I'm here partly because I'm so excited that you have this great new chair who I've watched develop from being an early stage investigator, and you're in fantastic hands. There's hardly anybody out there in this generation who's as generative and as brilliant as Matt. So it's part of the reason I came was just to share with you in some ways to celebrate. I think it's a whole new era for the department and an opportunity to do some fantastic science at a time when the stars are getting aligned in almost every way except in terms of money. The other thing is that, as Matt said, I trained here, and I doubt there's not anybody, almost anybody in the room who would have been here when I was here in the 1970s, which is, for many of you, was before you were born. But on that note, it's a funny thing. It wasn't just that I trained here, but my two children were born here, and actually my first grandchild was born here as well. So kind of like sea turtles, we've been printed here. My wife and I keep coming back in one form or another, and it is always felt a bit like home. So whenever there's an invitation, I usually can't wait to find an excuse to get back to the Bay Area in some format and have a chance to do some of these hikes and see some of the people and just some of the visual experiences of what it was like in the 1970s. Not a lot of that left, by the way, but it is still great to be back. I was trying to decide what to talk about because there's so many things that would be fun to discuss with you. And I think what I will do is kind of take you through a quick kind of a chef's tour of the world as I see it right now, and then try to run the movie forward 10 years and look back at where we are and think about what we maybe we'll have wished in 2023 we had been doing in 2013, how we might have wished that we had addressed things that are with us now and need to be thought about in some new ways. So you could call this Rethinking Mental Illness or The View from the Future or something like that. But let's start by going to the past a little bit and thinking about where we've come in terms of biomedical research. And I want to make the point that actually we don't celebrate this enough, but there have been spectacular, really spectacular accomplishments. So when I was here as a resident, the most common form of childhood cancer was acute lymphoblastic leukemia, and it was killing about 6,000 children a year. And that was over 90% fatal. Today it is over 90% of the time cured. Heart disease, which in the 1960s, even into the 1970s when I was with SNA, was killing about 1.5 million people a year, mostly men in their mid-40s to mid-60s, had been largely, much of that has been averted. There are literally 70% reduction, or 67% reduction in deaths from cardiovascular disease, 1.1 million people who historically would have died if they kept the same trajectory today do not have even ischemia because of preventive interventions, or in some cases, intervention treatments. AIDS is perhaps one of the most remarkable success stories. It's incredible that a disease that was killing at least 50,000 people a year 15, 18 years ago, we see a 60% reduction in mortality. In February of this year, the federal government now declared this to be a chronic disease. It's no longer thought to be an acute fatal illness, which is just stunning for any of us who lived through that epidemic. One we don't talk about so much is stroke, where again, we've got about a 30% reduction in mortality and 70% of people who can get to the emergency room within the first 3 hours after an event will never even be admitted. They'll walk out of the emergency room because of clotbusters and other interventions. So in somewhat contrast to those spectacular stories, you look at something like suicide, which is where we live. the issue that all of us in this room need to be thinking about. And what's so striking is the lack of progress in terms of the numbers, in terms of public health measures such as mortality and morbidity. In fact, in this particular case, we're now at over 37,000. It's difficult to know exactly how many of those deaths are related to mental illness, but even the most conservative estimates would say that more than half. The textbook figures that 90% are related to having a mental illness. Those numbers don't ever really mean anything unless you put them in context. And here's the context. That's twice the number of homicides. It's more than the number of traffic fatalities every year, and almost twice the number of deaths from AIDS. And what is perhaps most disturbing to me in the job that I have is the homicide numbers used to be higher, and the traffic fatality numbers used to be much higher. And of course, the AIDS deaths were much higher. All of those have come down. Suicide is almost conspicuous in the fact that it's trended up or hasn't moved at all, depending on which demographic group you look at in this country. So for those of us who think about the challenge of how we help those with serious mental illness, this is not a pretty picture. And it's not just suicide that contributes to mortality. There's a wonderful paper in the American Journal of Psychiatry just about 2 or 3 months ago from Sweden, looking at in a system where they have really good health care, that is, good access to health care and spectacular records, and following people with schizophrenia throughout a lifespan. And the remarkable thing there is that even there, with good access, relatively good care, good records, 15 years fewer, 15 years shorter longevity for males, 13 for females, and those with schizophrenia, not because of suicide in this case, but mostly because of cardiopulmonary disease and some metabolic diseases as well. Now, mortality is perhaps the easiest piece of this to measure, most difficult to talk about. It's important to realize that morbidity is also an issue. So when you look at just the disability from serious illnesses, maybe a bit of a surprise, but especially this is really reflecting only the group of people between the ages of 15 and 49, you can see that neuropsychiatric disorders account for more morbidity, that is more disability, measured here as disability adjusted life years. Kind of economic statistic of how you can begin to quantify what these illnesses do in terms of disability. We're number one. This is not a place where you necessarily want to be number one, and yet we're number one by a long shot for a couple of reasons. One is that disorders are very prevalent, they're very disabling as well, but perhaps most of all because these are the chronic disorders of young people, whether you're talking about autism, schizophrenia, mood disorders, anxiety disorders, substance abuse. These are the medical problems of people in their adolescence, 20s and 30s, and that's the part that's getting captured here. And many of these take people out of the life cycle for a considerable period of time. I live in Washington, and there you can talk about morbidity and mortality all you want, but what people really care about is money. And it's really striking for making this case as well that when you look at what are the cost drivers in healthcare, mental illness is way up there as well. These data are from a group from the World Economic Forum, a group that was formed to look at what are the challenges in the developing and the developed world as we go forward over the next 2 decades. What should we be thinking about? And they decided to really focus on non-communicable diseases because more and more we understand that those are the issues that developing countries are facing. So they thought about cardiovascular disease and cancer, and then they put in respiratory diseases and diabetes, and they wanted a control condition where they were sure was kind of not much to look at. So they put in mental illness kind of at the last minute. And we're shocked to see that mental illness was actually a greater cost driver. They assumed that was a problem with the model. So they went back and they did this with 2 completely different models, and they ended up with the exact same data. So very disabling nature of the disorders. And there's one other factor which I already alluded to, which is what the real cost driver here is. And that is that both in the developing and the developed world, people with mental illness are so much more likely to develop heart disease, diabetes, and a whole range of other problems on this graph. So these become the gateway conditions for chronic medical illnesses that are extremely expensive. And as we often say in the global context, no health without mental health. You really have to pay attention to this if you want to drive down these sorts of costs. As far as we know, within the United States, it's really hard. We don't really have a system that lends itself well to doing the accounting, but our best estimate for serious mental illness is that we're somewhere north of about $312 billion a year when we last looked at this about 5 years ago. So I guess a question you'd have to ask is, given where we are relative to these other areas of medicine that make so much progress, what is the problem here? And certainly one aspect is that for us, diagnosis is still very much by observation, and it's very late in the course. That's quite different today than cardiovascular disease or even many forms of cancer. We don't know cause, almost by definition, because if we know the cause, it becomes neurologic or endocrine or something else. And therefore, we don't have a really good system for prevention or preemption in the way that we might for many medical problems. Our treatments are mostly still trial and error. This is one of the very few areas in medicine, and maybe the only area, where when you bring together both advocates and scientists and academics, they don't talk about cures. It's really interesting. There's a lot of interest in treatment development, and nobody even formulates that we should be working towards a cure for autism or a cure for schizophrenia. And it's one of the very few areas where people are not focused on vaccines, which has really revolutionized the way we think about many medical disorders, including type 1 diabetes, with a huge breakthrough here at UCSF just in the last month with a new vaccine that looks like it may really make a difference for type 1. So bottom line here is that, and this I promise is the sort of end of the Debbie Downer part. You didn't, 8 o'clock in the morning, Matt, you can't, we have to have some good news here. So prevalence is not decreased for any illness, and mortality is not decreased very much. And that's got to change.